conference. And just for those of you for the schedule for upcoming next week, we're going to have a little review of CROI, so please join us for that. But today we are really, I am very thrilled to welcome Dr. Tom Quinn from down the hall. So I was like trying to figure out how to introduce this person, and I was like looking through all of the, you can spend a long time reading all of the things he's done. So I'll just pick a few. So he went to Notre Dame, as did I. Go Irish. And then he went to Northwestern for medical school. And then, as I understand from not reading but hearing, the decision to then pursue the next steps in his career was somewhat happenstance, but lucky for all of us that this is where he ended up in HIV and infectious disease. He has like every honor you can imagine and degrees from everywhere that he has time to travel to. Is a member of the Institute of Medicine, has been an advisor to PEPFAR, to the UN programs, to the FDA, to everyone you can think of, and has done really practice-changing research around prevention of transmission and around transmission between serodifferent couples and epidemiology of HIV all over the world. So we take him for granted, or it is possible to, because he's here and so friendly and enthusiastic. But I think the one other thing I'll just mention before I introduce him is, before I let him take over, is he is a model for just having joy in your work. I feel like if anyone were describing him, they would describe how much he loves thinking about these questions, and it just permeates everything that he does. And I think that's the thing that carries us through the difficult times and makes us all just so grateful to be doing what we're doing. So thank you so much for coming to us and giving us this update today.
Thanks very much, Eileen, for that introduction. Happy spring to everyone. And on the spring note, it is going to be a bit uplifting for the first half of the talk. Not so uplifting for the second half, but we'll try and throw a few tidbits into it. That should help. So before you leave, you don't go out totally depressed. Here's what I would like to present in this next 45 minutes. Going over the current status of HIV globally. Now, those numbers come from UNAIDS and WHO, and I'm going to reflect most of those. That's my references for that. It basically is the beginning of 2025. So the data for all of 2025 isn't completely in. So you'll see 2024 listed for some of those. I then want to go over the impact of the interventions that have taken place over the last 2 decades, primarily PEPFAR and the Global Fund, and review sort of the progress in what we call the cascade of care, pertinent to all of you involved in the clinical care of HIV-infected individuals. And then the last half of the talk will really go through the current threats to HIV control, which primarily comes down to funding and leadership issues, and try and project what the impact of those threats will be on the future of HIV. So to begin with, we go back in time. The beginning of the epidemic's 1981 in terms of its recognition. Since that time, 91 million people have been infected with HIV, and about 50 million or more have died, especially during those first 2 decades when we didn't really have effective treatment. Right now, living with HIV are about 41 million people globally. That's a 27% increase over the past decade. Part of that, if you look at prevalence, which is pretty much being reflected here in millions of people living with HIV, and it's going up, is because of increased survival. But it's also increased infections, which I'm going to go over. If you were to say, well, overall, what's the prevalence of the infection? If it was the US, and we'll get to the US, that's fairly straightforward. but it's quite diverse throughout the world, with Africa having the greatest burden of HIV. Always has, always will be probably. And you can see by the color grading, and I update this every other year or so to try and reflect changes in the different regions. But you can see Southern Sub-Saharan Africa, Eastern and Western Africa having the greatest burden, but Eastern Europe with Russia, Ukraine, others having relatively high rates as well. And we'll go through some of those dynamics. In terms of living with HIV, as I mentioned, it's 41 million. The incidence in the past year, we're talking actually for these data, 2024 was 1.3 million. Doesn't look like that declined any in 2025. So that number's probably hard and fast. And in terms of fatalities due to AIDS, 630,000 deaths estimated to have occurred from that disease. So if you think about the 1.3 million new infections that have taken place, about 50% of those are in sub-Saharan Africa, reflecting that very high prevalence that I just showed you. About 300 of the daily infections are occurring in children still. Prevention of mother-to-child transmission has been limited in some areas, and it's still resulting in transmission to those newborns. On a daily basis, about 32 new infections are occurring among adults, half of which are among women, and 1,000 or a third among young people, 15 to 24 years of age. So these are just some of the dynamics of what's happening globally, different within each region. The good news, and I said the first half of this talk is going to have a lot of good news, is that mortality due to AIDS has declined dramatically, as reflected in that sort of greenish curve. That coincides with the rise in percent of people who are infected but are on antiretroviral drugs. And we're talking about 78% of people who are HIV infected being on treatment within the last year or so. And you can see it's been a gradual one. In the US, we started around 1996, 97 with combination ARVs. But you can see as getting to the vast majority of infected people globally, it's been a steady rise in the use of antiretroviral drugs and consequently decline in AIDS mortality. But as with prevalence, that differs when you go to different regions of the world. So this is the percent decline in AIDS-related mortality since 2010. Just using that as a beginning point and going to 2025. Represented by region. And what you can see here is that the declines in mortality have been really quite dramatic globally for the Caribbean, Western and Central Africa, and Eastern and Southern Africa, the places where the vast majority, over 60% of HIV infected people reside, and hence as ARVs got in there, you see a much lower or dramatic decline in mortality. And you can see that starts to taper off as you go to Latin America, surprising. And remember that, because when we get to incidence, you're going to be surprised by some of these numbers. Obviously, the Middle East, which is a disaster for the present time due to the conflict, but also prior because of stigma with HIV infection in that region. And the one where mortality is still increasing is actually in Eastern Europe. Again, Russia and Ukraine dominating that. And again, conflict associated with some of that. Now, Eileen mentioned about treatment, decrease transmission. U equals U, right? Well, if we're getting so much antiretroviral drugs out into the populations, what impact are we having on overall incidence in these populations? And this is the best curve that you can imagine in terms of incidence. Yes, I mentioned 1.3 million people became newly infected this past year, but comparing it back to 1995, before we had antiretroviral drugs, it was on a steady rise, going up to 3.54 million new cases of HIV infection each year. So there's been a steady decline, coincides with viral suppression due to the use of antiretroviral drugs. Overall, globally, if we just go from year 2000, a 38% reduction in new infections. So this is really great news, but not the best news in terms of reaching targets. Those two little dots at the bottom and the far right were the WHO and UNAIDS targets for new infections. And they were to be at 200,000 new infections. And instead, we're at 1.3 million new infections. So we have a ways to go. And we're going to dissect why we're not meeting some of those targets. Like I showed you for mortality, you can also look at incidence by region. So the very first bar, this one, is globally. So for the whole world, a decline I mentioned in that previous graph, 38%. Here it's 40% from the previous year. So we're making some headway on that. But you can see the biggest decline is the place where the largest population of HIV-infected people are getting put on ARVs, and that's sub-Saharan Africa. 56% decline, 55% decline. Really impressive. The Caribbean doing pretty well. Asia, Western and Central Europe, North America, yeah, okay, but not as dramatic. Again, the numbers aren't as large there as they were in Africa. The three areas to watch where the epidemic is still spreading at an increased rate is really, as I mentioned, Eastern Europe, Latin America, which was a surprise, I think, to many people. That really shouldn't be so much the case, but it has been. And then Middle East and North Africa. So they've had an increase of 94%. That's only going to keep going up with the current conflict. There's just no avoiding that. So that's if you look at bar graphs. But again, I thought it might be interesting to look at these curves to show you the declines as ARVs got into the region. So it's the way these are dated is 1990 to 2024. And the top three show the best declines in new HIV infections, which is what we're working towards. And you can see that both Asia, Pacific, Caribbean, Eastern, and Southern Africa, the most dramatic. And again, those percents are reflected in those bars in the previous ones. Here is a dissection better of the areas where it's really starting to increase. Here's Eastern Europe, Latin America, Middle East, and North Africa, all going up as we commented on. So how did we get here? You know, I've given you a lot of statistics, but how did we achieve some of these successes, really, and declines in mortality, mostly declines in HIV incidence globally? And why are we failing in some of those other places? Well, to answer that question, I always go back to where were we in year 2000, all right? And if you go to sub-Saharan Africa, where 67 to 70% of all new HIV infections were occurring at the time, this is what you were finding. It was the leading cause of death, making up 1 out of 5 fatalities in sub-Saharan Africa were due to HIV infection. It was really a disaster in the region. And this, I tried to put together from one of my old slides, that those first 2 decades of the spread of HIV, without any ARVs available, did the following to Africa, Asia, and some other areas. Developmental gains of 3 decades totally erased. And I'll show you some of those curves. Economic decline of these countries had gone down by 40% in some of the countries. Their health systems totally in chaos. Political instability, security concerns, because the military was all infected with HIV. We're seeing more and more increased numbers of orphans, the parents dying from AIDS, all resulting in immense humanitarian concerns. And as treatment came to the US and to Western Europe, it wasn't making it into these areas. And so you get this huge inequity in access to treatment. What this all resulted in was a calling in the Security Council that this disease, HIV, was creating a huge security concern for the world. And they came out with a declaration. You can see the United Nations put up the AIDS ribbon. This is the Security Council. It was unanimous. It's one time the countries all came together that they needed to do something about this inequity in access. And they created, in that year, the Global Fund for AIDS, tuberculosis, and malaria. A few dollars rolled into it, but it was, at least it was a start. The big surprise was President Bush giving the State of the Union address in 2003. Now, remember, we're on the heels of 2001, and he gets up to talk about the state of our union, and this is what he says. And I always love to quote it because, you know, here was someone very unpopular with the Iraq war that was going on, with, you know, the attack on the Twin Towers and everything. But he takes 5-10 minutes out of his talk to say the following: to meet a severe and urgent crisis abroad, tonight I propose the emergency plan for AIDS relief, a work of mercy beyond all current international efforts to help the people of Africa. Seldom has history offered a greater opportunity to do so much for so many. I read that because I can't imagine our current leaders saying that. And we just had a State of the Union address, and I didn't hear anything quite like this. So, this is his legacy, President Bush's legacy. And he became very popular among AIDS activists at the time. So he really wanted to do something. And this was the goals of PEPFAR. It was going to be a 5-year program. That was it, 5 years. But in 5 years, they were going to prevent 7 million new infections, treat 2 million infected people, care for 10 million HIV-infected orphans and vulnerable children. There were 13 countries that were identified that they wanted to put the concentrated effort, and it reflects that prevalence map that I showed you. So, the architects of PEPFAR really had this down pretty good. The question was, it was just for 5 years. Was Congress going to approve it, number one, and then reauthorize it? Well, fast forward to today, PEPFAR is now in 55 countries as of 2024, and we'll get to 2025. And these are all the countries that 15 million for 5 years actually morphed into 6 billion a year, or if you will, $30 billion over 5 years. So huge increase. And they decided to put a lot of money into the global fund. So multilateral and bilateral assistance, something that had never really been done before for another disease. So HIV really led the way. And I showed you that one graph about mortality going down as treatments going up. Well, right now we have 31.5 million, 32 million people on antiretroviral drugs. Go back to 2005, and it was 5% of the infected population. Now we're at 77% of the population. Really, what made that happen was PEPFAR and Global Fund. They basically make up 80 to 90% of this ART response. So really, international assistance really has had multiple payouts over the years. Even the number of orphans, which had hit 18 million children being orphaned by the loss of their parents due to AIDS, that is now on the decline as mortality has been going down. So really good news. So let's then structure, where are we going? If we've got 32 million people on treatment, what's the gap? Who do we need to get on treatment to really control this epidemic? Well, it's 9 million more people. That's achievable at the 2023 kind of rates. And we'll get to how we're going to get these 9 million other people on treatment. So we have a treatment gap. Where is that gap? It's not the United States per se, although we will get to the US. It's really still sub-Saharan Africa. They make up 50% of that gap that's still there. But I still worry Asia and the Pacific, and that may be India and China driving that, and Eastern Europe because of the rising new infections. So we still have quite a few different regions represented in the graph. But let me summarize the legacy of PEPFAR, because really we need to applaud this. This is the US citizens, this is Congress, the president back at that time, who really were the thought leaders of this. They saved more than 25 million lives over the last 25 years, supporting ART treatment for 21 million. Phenomenal. US funding for PEPFARs, if you add it all together, it's $110 billion. 1.9 billion in 2004, steadily rose to 6.8 billion in 2024, 2 years ago, well, a year and a half ago. And remember that number, 6.8 billion. Largest commitment by any nation to address a single disease. So it really set the stage. Supported testing services for 65 million people in 1 year alone, 2024. And it counts for more than 90% of pre-exposure prophylaxis initiations. After we found out in Africa that voluntary male circumcision was protective in decreasing acquisition, PEPFAR funded, this is all PEPFAR, 35 million voluntary medical male circumcisions, mostly adult men. Prevented 7.8 million babies from being born to an HIV-infected mother through PMTCT. Provided care for 7 million orphans, supported training for a large number of healthcare workers, and US became the single largest donor to the Global Fund that I mentioned that UN had started, $28.2 billion, so a lot. Now, some of you have seen this particular graphic before. It is my favorite one, and I always say, how can I capture what PEPFAR and AIDS relief has really done? Well, this is life expectancy in 6 African countries, steadily increasing prior to the advent of AIDS. right? Starts in 81. So look down on the x-axis and you can draw your lines. And then life expectancy drops dramatically. Times in some places, 2 decades of life. So instead of having a life expectancy of 65, it's now 45 in those countries because of AIDS hitting young adults and so forth. It then goes back up as we bring treatment to the forefront. And then there's a little slight decline. It's COVID. So this actually captures COVID in those countries. So there's other ways of measuring the impact of PEPFAR. You can look at GDP per capita increase. During the time of the PEPFAR in Africa, there was actually an increase in GDP. Girls and boys out of school, that declines. Child mortality really declines. Immunization rates, because we've built their health systems up, actually increases. So the strengths of PEPFAR are really in these. I'm not going to go through them, but it's universal testing. It's universal treatment and care for those who are infected or are partners of infected people. It invested in health system strengthening and also worked with the partner countries for socioeconomic impact. Many of us here worked and have worked at the IDI. This is the waiting room at the IDI. Just the people were now able to come get good care, get treated, get followed up, and have full access to single drug antiretroviral drugs. Now, the measurement that PEPFAR and WHO decided on was the cascade of care. And we've seen that for the US multiple times. It's, 95% of people should know they're infected. 95% of those people who have that knowledge should be given antiretroviral drugs. And then 95% of those people should be virally suppressed. Very easy metrics to follow. Over each of the years, these are the bars for each year, it has steadily increased. So really good news. Viral suppression of 73% isn't something to, really get excited about, but it's making progress. It's close to the 95% in that third denominator as you work your way through the numbers. But like the regions have differences in their epidemics and their control of their epidemic, we also see cascade of care varies. And it partially explains why incidence is going up in some of the regions because they've not reached that viral suppression rate of 95% of those who are on ART and so forth. And I put little arrows to draw your attention as to back that statement up. And it's the Eastern Mediterranean region. It's the Eastern European area. In contrast to the African region, which is already at 78% viral suppression rate. I mean, that's why it's reflected in those global numbers so well. Well, how are we doing in the US? How does this all compare? Let's look at our own epidemic. This is where you work. And I have to, I brought up George Bush. I'm going to bring up President Trump. His first term, 2019, he gives the State of the Union address. Now, it's not like George Bush, but he actually announces a new plan that he has worked with Tony Fauci and other people to achieve. And this is the scientific clinical basis for a plan to end HIV. So I don't know how many of you remember that State of the Union address. We gloss over it now. But it's treatment as prevention, get everyone on ART, get them tested, get them on ART, and for their partners, pre-exposure prophylaxis and those at risk. And they give goals. By 2030, we're going to have a 90% reduction in HIV infected people. 75% by last year. Okay, so how do we do? This was 2019. He had 6 years to get there. He always lives up to his promises, right? Well, we have 1.2 million people living with HIV. That's been the same number for every time I've given this lecture. It just doesn't change. 13% are still unaware of their status. 700,000 Americans have died of this disease since the beginning. And in 2024, we had 38,000 people newly infected. 67% still among gay and bisexual men, not all PrEP, obviously. 22% among heterosexuals, 7% injecting drugs. This is, I have to share this with you. I went looking for the statistics. Well, forget CDC, folks. You're just not going to get up-to-date statistics anymore. Sad. But instead, this administration launched a new dashboard. It's called AHEAD. How many have heard of this? All right, Joyce reads it every day. Of course you know it. America's HIV epidemic dashboard. So the data is September 2024, and this is COVID, this drop in reporting, basically. So that's an artifact, I believe. But these are the numbers for the last 2 years, and they don't show any decline. So whatever happened to President Trump's grandiose plan to end HIV, it doesn't look like it's going to meet the target. Shown in that blue dot at the end is the target, where we should be. And we're not even inching towards it. So not doing too good. What regions? In 2019, it was the Southeast. Guess what? In 2024, it's the Southeast. The others still having their rates. This is per 100,000 population. But you can see DC, Maryland, Virginia, Delaware, we're all considered in the Southeast region. So I mentioned who's at risk. If we look at ethnicities, African American, Hispanic, and then white population, but you can see the minority populations having the greatest numbers of new reported infections. These are not estimates, these are actual reports that went into that dashboard. Joyce, I looked at the dashboard before I looked at this, hasn't been updated. It's almost like they're embarrassed to update it. It's so weak. How's our viral suppression? 95, 95, 95? Well, it doesn't look like we're doing too good. Now, Jeannie knows I often show the Ryan White numbers because they're good. They're like 90, but Ryan White doesn't provide care to all HIV infected people. This is again from the AHEAD dashboard, and it's showing absolutely no change in viral suppression. And as long as this number stays at this, we're going to get more infections because PrEP isn't being taken up by as many people as they should be. So you can really project, if you wanted to, where we will be in 2030, especially under this administration. And it doesn't look like we're going to make any change in that. Now, how are we doing for the funding in our country? It's Ryan White is the safety net for HIV infected people, particularly among those impoverished. Well, the numbers, if you look at what Congress is appropriating, they look pretty good. But if you adjust them for inflation, you look at that green line or whatever color it's projecting, it's actually going down in terms of spending power. And that's Ryan White issues for 2020. And there were $2.5 billion for Ryan White. So Congress was keeping it up, flat funded, obviously, but even a decline in spending power. What's more worrisome is ADAP, because that provides the drugs to the really impoverished people. And this was just in the New York Times last week, trying to keep this up to date for you all. Right now, ADAP supports 25% of the 1.2 million people with HIV for drug support. 18 states are reducing that funding, and 5 more are on the cusp. And that shows by the color shading which states are really dropping ADAP. And the sad part is that it's hitting states that still have a fair number of HIV infected people, and particularly the South. This also looks at the funding levels for ADAP from the federal government. It's close to $1 billion each year. And you can see it's flatlined since 2010. All right. If you adjust once again for inflation, it's really half of that in terms of buying power for the drugs. The state that really got the most attention with their new Surgeon General, who doesn't believe in immunizations, the state governor, reduced income eligibility from 400% of the poverty level to 130%. Now, I always say, well, what does that really mean? Well, eligibility in the past was if you made less than $63,000 a year, you'd be eligible for ADAP. That's down to $20,000. So it knocks a lot of people out. And they also said, we're not going to cover Biktarvy for 16,000 residents now living with HIV. So if you're HIV infected, Florida is not the place you want to be. So for the US, the current challenges are HIV incidence is unchanged. Viral suppression is unchanged. Federal funding for control programs and treatment have been effectively reduced, even though the numbers look good. Current federal and state laws, regulations, like in Florida and other places, are putting up structural barriers for treatment. Patchwork of insurance is a disaster for treatment and for PrEP. And we have insufficient numbers and fewer people going into the labor workforce for HIV expertise. And stigma remains a challenge, as well as disparities. So that's the US. Let's go globally now, since that's where I started. The biggest threat to global control is the United States. And it all started 1 year ago with the executive order to hold all foreign aid, put on hold. Now, yes, the Secretary of State, Rubio, gave a little exemption to that, but by and large, this is what had the greatest impact. USA, where all the international assistance abroad was flowing, that was closed, and it's not been reopened. It's basically gone. That limited waiver, no prevention activities, but you can buy drugs. $40 billion were cut from USAID, and PEPFAR was up for reauthorization. It was not reauthorized for the next 5 years. So what we've seen, and I was with the NIH a couple of years ago, is this federal workforce being decreased. 20% for both CDC, 20% at NIH, scientists, directors, advisory panels. The judge just threw out the immunization advisory panel, which was a farce to begin with. The people that were giving out the grants or helping do the research were being decimated. And we withdrew from WHO in the Paris Agreement on an environment. Well, what impact does that all have financially? Well, HIV funding. Let's just focus on that for a second. This is the pie of those millions of dollars going to health, what we call global health. HIV made up 60% of that if you look at the Global Fund and PEPFAR. So, there's almost $7 billion was going towards HIV. Then the rest, maternal child health, tuberculosis, malaria, global health security are the other pieces of the pie. Well, what does that mean in terms of administration of these dollars? Well, this is the curve or the bar graph of the U.S. funding for PEPFAR, just PEPFAR from 04 up to 25. You can see it really did great. That green bar happens to be emergency funding for COVID. So the rest has always been flat funding right up to 2025. Here is U.S. aid and the global health outside of the U.S. that was to be addressed. So by closure of U.S. aid, you'd immediately affected all funding for maternal child health, global health security, tuberculosis, as Dick knows, family planning, the malaria. Now, PEPFAR was divided between U.S. aid and CDC. So if you were receiving CDC administered funds in Uganda, say, so the money was there. If it was being a provider that was getting U.S. aid fund, forget it, it was gone. And then nutrition is listed as well. But here's the impact. Some of this is from CROI that I was able to pull out. What's the impact? First of all, there was a systemic disruption. Sudden withdrawal of U.S. funding created a silent crisis. There wasn't as big an outcry, and it wasn't as noticeable unless you were a recipient of a TB grant, like some. 47% of 32 surveyed countries by WHO reported disruptions in their HIV services. The prevention programs just collapsed. In Nigeria, I give as an example, and that was presented at CROI. 390,000 people receiving PrEP dropped to 7,000. Just prevention was not going to be supported. The laboratories were no longer getting funding to do viral suppression measurements. And so a third of them said that they had lost essential lab services. And the decrease in funding was leading to a projection in the reversal of all that progress I had tried to show you in the beginning. So the modelers have a field day with this. And I could have pulled a whole bunch, and there was a whole session on the modeling impact of this disruption. And it's, if any of you want to look at it, Jeff Garnett probably was the best presentation, but I had to pull all those slides because of time constriction. But to summarize, if some of that funding's not restored, and we're going to talk about that, potentially within the next 4 years, all right, 4 years, 4 million new additional HIV-related deaths will occur, and will go up to 6 million new infections as a result. And that's obviously, the curve is pretty obvious that the numbers are going to shoot up. That's if the disruption that we witnessed in 2025 doesn't continue. Or it did continue, then you'd get those big increases. But there's a big but. We are getting money. And you have to look and dissect this very carefully. And I want to walk you through this. So here are the different buckets, if you will. So PEPFAR. All right. In the continuing resolution, we were getting $4.7 billion. President Trump's administration said, let's cut it in half and just do 2.9 and get rid of USA. The House said, no, we really want to increase it to 4.7. The conference decided on $4.6 billion. Well, that's a 2% decrease from the continuing resolution. That's not bad. That's something that, Congress responded to that. Where'd the money go? It all goes to the State Department now. No U.S. aid. No CDC in this. It's all being managed by State Department. So call up Secretary of State Rubio if you think you're being shortchanged. The Global Fund, this was really interesting. So we gave them 1.6 billion, and the Congress did decrease it, but it's at 1.2 billion. You know I know it's a decrease and inflation adjustments. It's a bigger decrease, but it's there. TB didn't do bad, Dick. But you could comment on that. And malaria was flat funded. It got it. So how is this money? I mean, where is this money? I mean, that's the big question. Well, here it is. All right. So this came out in September of 2025. It's only 6 months old, folks. So this is really hot off the press. Has anyone read this? All right. Maybe you could comment about it. This is my take, a little tiny summary. So if you read through it, it's a path of declining U.S. support over time as the recipient countries take on the financial responsibility of caring for AIDS patients. You can't really argue with that. I mean, there had to be a time when the host countries would start to take on their own responsibility of caring for their people, right? I mean, that's the reasoning behind that. Hold on. It includes a focus on health commodities. Let's buy the drugs and hands off on its management. And we'll start out close to 100% of whatever we gave you last year. But then we go to 60% and you go up 40%. Then the next year you go to 50%, 50%. Within 5 years, the US is out and the other countries are handling the host countries. All right, how does this work? So they go to each individual country and they do a pact. That's what they're called, pacts. They're signed agreements. Some call them MOUs. Compacts is the other term. And in fact, 24 countries have signed on because they don't have the money to do this. I mean, if they don't sign on, they get nothing. All right. So it's either you take our agreement or you get nothing. So the recipient countries, the U.S. has committed 20 billion health aid over 5 years. So that sounds pretty good. But if you're the host country, say you're in Nigeria or Uganda, you must commit to increasing your own health spending. That's good. Each year, U.S. support declines, as I pointed out, while they increase their spending. The recipient countries must also agree to provide specific country personal health data. All right, this is an infringement, without a doubt, on provision of personal health data. And specimens must be provided to the United States so that we can work on infectious agents that might pose threats. And if we develop a vaccine against a new epidemic, we have the rights, they don't. So there's no commitment that they get access to the vaccine or the biological, enterprise. No guarantee, as I say, no guarantee of access to the research or vaccines that get developed. Now, New York Times decided to cover this as well. In Zambia, they pulled out. That agreement actually spells out American businesses must have unfettered access to Zambia's vast mineral oils, or mineral deposits. And it's evidently pretty rich. And Zambia is saying, wait a minute. And they go, look, you're doing that for China. You need to do it for us. Remember, this is coming out of the State Department. We don't have health people doing this. This is very politically driven. And the U.S. has requested changes to the country's economic governance. So they want to see how the money's being spent and so forth. The critique of this, on one hand, it's positive. It starts to give sovereignty to the host countries over their health. You can't argue with that. It's the quid pro quo. We give you money, you give us the other thing in return. These are some of the critiques. AIDS used as a political tool. It's narrow focus. It does not even address immunizations, maternal health, nutrition, all those things that were in PEPFAR. Reduced oversight. We'll buy your drugs, but we're not going to tell you how to administer it to your population. State Department's running this. Well, there's an RFA, if anyone's interested, worth $100 million each to help the State Department run this, to give some input. Go to the country, see how it's being spent. A lot of people don't want to touch this, but other NGOs will, because there's no USAID money to support them anymore. And there is a risk to global safety. Failing to support comprehensive global health systems strategy could result in rapid spread of infection. So it's a worry. And if you say, well, wait a minute, how does this work out per country? And it really varies a lot. Look at Uganda. I put a little arrow next to it. The red bar is all PEPFAR care, if you look at it from a financial perspective. The green is the domestic. And what we're saying in the next 5 years is that's got to all reverse. The green's got to be way up and the red shortened down. Kenya, which hasn't signed the agreement, and nor has South Africa, is because they don't want to agree to some of those stipulations, and they are already providing care and to a certain degree to their population. They just have to increase it a little bit. But if you're in Liberia, you need the US funds, let's face it, and some of the others. So let me finish up. My conclusions, and these are mine, is that thanks to PEPFAR, and you know I really applaud what PEPFAR's goals have achieved. And the other treatment programs include the Global Fund. 31 million people are now on treatment that were not on treatment 20 years ago. And it's safe, it's single drug, it's effective, and we're getting reductions in viral load to the same level that's in the US, in Africa. In some places in the communities, like Rakai, we're at 95% viral reduction. So, and if you look at 95-95 goals, Cascaded Care has been doing well up to a certain level. And ART's been fantastic at getting down to a single drug, and it's generic and easily affordable in most places. But here are the challenges. We still have that gap of 9 million people not on treatment. If viral suppressions start to go down because of lack of funding, we will see new infections occurring. The funding has been a shock to the system. How well we're going to recover from that, I don't know. The America First plan strategy, we'll have to see how that works out. As I said, over 20 countries have already signed on. Those planned reductions in funding and transition to the domestic governments seem a little unrealistic and worrisome, but we'll have to see. Governments are being given control. Expectations are challenging. Important they do not fail. Prevention is going to be hurt the most. But I told you I'm going to allow you to leave on a good note, and that's lenacapavir. All of you know about it. You're going to hear more about it from the CROI thing next week. But Gilead, the United States government, and the Global Fund have joined forces in partnership to actually bring lenacapavir to persons at risk in 10 African countries in 3 years. It's going to go from $28,000 a year for the trade drug down to $40 a year generic. $20 a shot. That's doable. And could really result in a decline in new acquisitions. My last graphic is that, and this is from 2018, it's old, but it says what I want you to leave with is that this battle on HIV/AIDS globally is far from over. And there's no way anyone can be complacent about the threat that it still remains to the lives of people worldwide. Thanks for coming today and paying attention. I ended 2 minutes early.
I have a question. So I've a question about PrEP. You know, we talked a lot about, you've made a great case for the impact of PEPFAR's expansion of treatment on reduction in incidence. There's still countries, areas you pointed out that have limited coverage and high incidence, Latin America and other places. But I'm wondering now, where do you think the biggest impact on the loss of PrEP is going to be on the incidence? And you know, it's great that there's going to be investment in sub-Saharan Africa on PrEP, lenacapavir, although, you know, you might argue that they're making some good progress with coverage, and their incidence is going down. It's places like Eastern Europe where coverage is low and incidence is high that would probably benefit the most from PrEP. So I'm just wondering.
No, you're absolutely right. The places that would benefit the most are those that are having increased incidence, as you point out. So Eastern Europe, the likelihood they can barely get viral suppression. So we can't even talk about PrEP there. I mean, they would truly benefit, but let's get the people treated who are infected first, and then roll out PrEP. Africa, which has the largest number in at-risk individuals, will always remain a great place to see the value of both treatment for U equals U and PrEP to prevent that acquisition because of the large number of people. I think it's a numbers game. I often wonder, what about India? India probably, similar to what I'm saying about Europe, is get as many people on treatment as possible and then start to do PrEP. The problem is that new initiative with lenacapavir, that's just for Africa. Right. But I know the Indian drug makers will be given permission to make the generic, and it will be available. I mean, once it's generic, it's $20 a shot. That to developing countries, that's still a lot of money. I know that. And you'll need international support to carry that out. The big question is what will happen with US support over the next few years. I was pleasantly surprised that Congress did at least appropriate the money, but it can always be rescinded. I worry about the political forces in this country right now about AIDS care. Dick.
So that gets to my question. What you showed is that the administration says cut the budget by 40%, and Congress says no.
Yeah.
So what's your sense of whether Congress is going to agree with these MOUs, having the country funding go up and the U.S. funding go down? They might not agree with that. What's your sense? Congress is going to.
Yeah.
The administration will ask for less money, but
they will.
But they might give it to them anyway.
Yeah.
That's what they just did.
I can't predict. I have not a clue what.
You're supposed to make us optimistic.
But I'm not going to make a prediction on what will happen between. I mean, so far, Congress has not said a word about the America First global health strategy. I mean, it's been radio silent. No one, I mean, they're focused on so many other things that this is low. And they see, at least in the first year, the funding is going to the country that needs the money, right? So they're going, oh, that looks good. And then we'll have to see what happens afterwards. The fact that what's being made public are these MOUs, and Zambia was, I mean, that makes the New York Times. It's not making the Washington Post or the, you know, or some of the other ones. The New York Times loves to go after this kind of stuff. So I think we're going to have to advocate more. I mean, PEPFAR survived. Congress did give all that money. And I have to think advocacy does help to support that. Eileen.
Thing that struck me from the George Bush quote from 2023 was that it was a moral argument.
Yeah.
And
that's how he took it. Yeah.
It's a financial argument of like, look at the, like, so what's the right mix of those things? Because I think, you know, I remember one time someone presented a cost effectiveness study where they showed it was not cost effective to switch people to second line therapies, but that's because dead people don't cost any money, right? Like, I mean, like you can kind of in these like, so what's the mix of like the moral and the monetary stuff?
Yeah.
That you think will be effective in these calls of people?
Well,
Maybe not the White House, but in Congress, you know, like, since they're the ones who seem to be listening.
they are listening. They do see the moral imperative and equity issues in these poor countries. And a number of the senators have gone to African countries, have gone to Asia. They see, you know, the poverty and the impoverishment, and that there's no safety net like Ryan White in some of these cases. So I think they do come away with that. And we can argue that. What we always argued in our advocacy is this is soft power, doing the global health and providing assistance. It has its own political might to it. This administration doesn't believe in that anymore. It's quid pro quo. If I give you X, what am I getting in return? They're very definitive on that. We won't convince this administration. Congress, we can. Comes down to the midterms and you know, who's the voice in Congress come midterms, and will they push back more? Because otherwise, they will rescind what Congress appropriates. They've done it once and got away with it. They'll do it again. And take that money and put it into the war. They need $200 billion for this war. So, Jeannie.
Appropriate for very hard ones, so drugs, for example. But what was removed was the infrastructure for delivery for these programs. A lot of programs were decimated when they lost that money. And so then you can think about, you know, if you can't deliver the service because you don't have the resources or the infrastructure in place, that money can come take that money back. If they do any type of assessment, if they have the ability to do that, if that country can't execute it.
True. Oh,
I think that's what you gotta believe that's what they're hoping. Because everything is a business transaction.
yeah.
It's just.
It's interesting. As I was putting the talk together, I wanted to know what's happened to PEPFAR, and PEPFAR's gone. And not a lot of people say that. It is morphed into this new plan. There is no more PEPFAR. It's the America First strategy. That's the way forward. Whether Congress can start to, I mean, that's your question, I think. Can they, well, and Dick's too, can they impose influence on that policy? And it depends who's in, I mean, right now it's rudderless. But they are, and the other thing about the pacts, the compacts that they're doing, I mean, the countries are given like 3 weeks. You either get it or you don't, you know? Uganda signed it. I actually have the MOU. Steve Reynolds sent it to me. So I can read it and see what's been promised and how it's going to change. And right now in Rakai, which everyone's heard of, we're all waiting and watching and seeing how well does the Ministry of Health carry this out. And what's happened to PrEP. I think it's gone. But they're trying to get that lenacapavir and be one of the 10 countries. So time's going to tell. This is pretty all new. I mean, the strategy is only 6 months old. So it's hard to say. It's like PEPFAR was very slow to get started. Once it really took traction, it took off. I don't think anyway.
Do there seem to be any, sort of connections in the State Department with any public health people or anybody have any knowledge of any relationship given the shift in views?
So
for this funding?
the one person I do know, she has a lot of health experience. She's fantastic. She's wife of John O'Merman. But I don't know if she's staying there or not. It's Becky.
He's staying.
Yeah.
She is.
Yeah.
So she's fantastic, and she may be helping the architecture of all this. She's our go-to person, and she's been with PEPFAR before, and so she's experienced. But State Department lost 10% of their employees, and that division got sort of that where it's being administered, global health security, they got hit. So I honestly don't know.
He was on a panel of senators at Croy. This must have been, I mean.
Oh.
Do you remember this?
Yeah. Yeah.
He was there. I was like, oh, okay.
Yeah.
So I don't know. He was at Croy.
Yeah. And he's the one who gave the exemption, the waiver, to begin with. Otherwise, other people in that administration were deaf to any outcries. At least he did hear a little bit. So he did respond. But this is all State Department. They're in charge now.
Yeah.
Yeah.
The one place I think there's opportunities that there probably are still people that want to retain the first legacy.
Right.
In the Republican Party.
Right.
Yeah. Well, I think, yeah.
That there are people who have a moral compass, right? You know what I mean? Like, despite whatever, who are the most prominent people, that does exist. So it feels like as much as there can be a personalization of what's happening, that will resonate, and there are some of the people who have who will be able to, sort of
Chart a course. Yeah. Yeah.
A better direction.
Let's hope so.
Yeah.
Next weekend, No King's March happening around the country again. I mean, there's just midterms will make a big, could make a big, I don't want to predict that. But what about the US data? How do you feel about that?
Like it's that insurance patchwork, frankly. I mean,
yeah,
it's so difficult to implement these proven interventions because of, insurance and even Ryan White. I mean, there's just so much more need to prove that somebody should be getting A, B, C, X, Y, and Z.
Yeah.
And so I think it's just made it really challenging.
Yeah, Richard.
Well, what do you think happened from 21, the end of 24? Joe Biden was president. I think the Congress for at least 2 of those years was Democrat. DHE was in full power.
Yeah.
And allowed to be in full power. And yet your figures show, once we rebounded from 2021 COVID, maybe it's still COVID over there. The United States, just everything's flat. Why didn't, have we hit some type of ceiling for reasons beyond money? Beyond, I don't know, that's something, why, to me, that shouldn't have been flat from 21 to 24.
Yeah.
And it was completely, and I can't blame it on Donald Trump. Can't blame it necessarily on Republican Congress. I think most of it was Democrat Congress. And I think the money was rolling.
Well, that's
What happened?
that would be.
Is there some other ceiling we're not looking? Well, I mean, that's.
Well, COVID intervened, and
but did COVID explain the whole?
well, it explains the first 3 years probably.
Okay, well,
But that's how long we really suffered under that, and the money stopped, and it was all focused on. And then the debates over public health and
the money didn't stop. So they didn't take from HIV to pay for COVID in instance.
no.
So maybe it's still COVID. I'm not saying it's not.
Yeah.
But there's something. It seems to me like.
What about leadership? I'm gonna throw. Who leads it? I mean,
who led it from 21 to 24?
Well, I think the public health
Yeah.
infrastructure been decimated, you know,
In
so.
21 to 24.
Well, COVID, frankly, all of the HIV programs got shifted to do COVID, all of them. And so then, you know, and then plus, if you think about these cities and these areas where, you know, the public health is funded by the municipalities, you know, the problem with resources for cities and these health departments, the belief in health departments, I think, you know, it just made it very difficult to take that money and spend it and do the work. I mean, that's what was experienced here locally, was that everything had been shifted, people left, and then they couldn't hire. I mean, that's at least, I think, part of it.
Yeah. Certainly with the ADAPs that are going on now. I mean, I'm talking 26.
Oh yeah, I'm trying to figure out what happened. Is there something
in the good years?
Is there something we can learn?
Yeah.
From what should have been
You should just speak up, Kelly.
the better years.
Okay.
Yeah, Kelly.
So I'm Kelly Curran, and I work in the Center for TB Research now at CFAR. I was at Chicago leading their CFAR funded programs for 22 years previously. So, I mean, it's funny because I'm reflecting on a conversation I had with Jonna when he was still at CDC to get at your question, which is actually, I honestly think if you could fund PEPFAR partners to work domestically in the US and give PEPFAR I'm not kidding.
Oh yeah, yeah.
And give them the kind of targets that we had. And also if you had a single payer system, which is what PEPFAR is, you know, it's way easier to initiate treatment, to start PrEP in the old days, you know, before all this, but it was, you could initiate treatment and, you know, in Malawi in an hour, like there's no barriers, there's no insurance, there's no, you know, and the same that, you know, I had the privilege of running a very large program. We used to test 1 million people a year in Nigeria. And it's the same, you know, our viral load data, if people didn't come back and missed clinic for 2 weeks or late on their viral load, I would put someone on a motorcycle with a, you know, to go to their house and draw their blood at home. Like, and we were resourced to do that. And I don't think the resource, you know, I mean, that's the thing. There was no, the thing about PEPFAR was that it removed the financial barrier to delivering care. Like no longer were you constrained by like everything you needed, you just did it, you know? And obviously now we're in a situation where we built this incredible, beautiful program with tens of millions of people on treatment. And I have no idea how the government of Malawi is gonna pick that up and pay for it. They're never gonna be able to hire, you know, the difference with PEPFAR, again, it's not the drugs, it's the human resources. It's not even the nurses, all of the nurses are important, but it's the community health workers on their motorcycles, on their bicycles who go out and follow up everybody and deliver drugs at home and who when someone tests positive, they go and trace all their partners and they offer PrEP to all their partners. Like that was what existed, and we don't have that here. And a lot of it is because the care is so fragmented between Ryan White, AJAP, private pay insurance, Medicaid, you know.
There's nothing for PrEP. We
Yeah.
were just having this conversation about starting PrEP in the ED.
Yeah.
It's like it's like impossible. I mean, even with insurance, there's prior off,
Yeah.
blah, blah, blah.
Oh, yeah. In Uganda, we had,
In like Cote d'Ivoire, we were said, oh, we want to start PrEP in the ED.
Yeah.
Like, and people, you know, someone who's on PEP, for example, when they finish their 20 days of PEP, switch them to PrEP. Like, you just did it. Like, there wasn't any kind of like policy barrier as a partner. You just implemented whatever you needed.
in Uganda,
Yeah.
with the Rakai program, there's PrEP clinics.
Yes.
So you test someone, they're gonorrhea positive, treat their gonorrhea, and then you send them over to the PrEP clinic. And they get treated. Oh, we're done. Go, yeah. You know, in the old days,